Thank you for your time here today. My name is Dr. Das. I'm a consultant cardiologist at the Heart Centre. I'm also the digital transformation lead there. And lastly, just a conflict of interest, I'm also the CEO of the digital company that I'll be talking about in this presentation, the tool that we used for our NHSX playbook, which is the virtual clinic and remote monitoring of our post-AMI or post-heart attack patients at the Barts Heart Centre. So why did we first do this in the first instance? You know, our post-heart attack care was variable, it was inconsistent, a high volume of patients coming through essentially one of the largest tertiary heart attack centres. Patients were being seen in different locations, in inconsistent timeframes, more of it being lost to follow-up. And when we did get to see the patients, it was time off work. A lot of them had to come into central London. We had a lack of clinic space, in fact, just to see them and expand our service. And moreover, kind of an information overload for our patients who had quite a lot of questions, as you can imagine, after having a heart attack. Because of that lack of time, variable follow-up, we knew from our audit that there was poor medicines optimization of really prognostic medications for our cardiac patients. We know there's certain drugs that we have to get them up to the right doses to achieve the best long-term outlook. And then last, put that all together, we really didn't have any consistent way of getting patient-reported outcomes for our patients because, as I said, the variable follow-up did not help. So this was really what our post-heart attack pathway was. You have a heart attack, you have delays, the follow-up is delayed, we weren't optimized, and what does that lead to? Usually, and can do, recurrence of heart disease. And the last one, we know that due to this lack of follow-up, we really had poor engagement with cardiac rehabilitation. So, like most problems within the NHS, what was the core problem? We didn't have enough staff to deliver more clinics, we didn't have any more room space, and we didn't have enough time. So, to tackle this, we tried to look at this problem differently. With regards to staff, could we use allied health professionals to safely follow up our heart attack patients, be it an A&P or a pharmacist? And the other two problems, could we use digital solutions or digital tech to make our clinic utilization more effective, more efficient, and move it away from the traditional clinic room space? So prior to this, I'd already been myself working on creating a platform called a virtual clinic and remote monitoring platform. And the idea was to transform that more disjointed follow-up journey and make it more personalized and more tailored to the patient and give them more guidance on how they could navigate that journey more efficiently. And it consisted of a patient application where you could fill in questionnaires, health-related data, and try and get a lot of the information gathering that we do in our clinic prior to the appointment. And for a clinician, a remote care platform where we could see that information and utilize that. And the vision was to try and then get that data in the future, start using more intelligent ways of machine learning to see how we can inform and improve our pathways. And the vision was to improve patient satisfaction, improve outcomes, hopefully, and improve efficiency. So we thought, well, why could we not try and use this in one of our problems, the heart attack pathway? So this was the vision. Patients would be given the Ortus app. They would be remotely put in blood pressure, heart rates remotely. We would try and remotely up-titrate them, and then we would see them via video conference. And this was the kind of proposed pathway. And the long-term vision was to see if we can try and bring in some digital rehabilitation as well. So take each part of that journey that they had and try and digitize where we could. So we started on this journey, and the vision was to take, like all digital transformation, it's the most important thing is the change management process that takes place. So we started by saying, with the staff issue, could we get allied healthcare professionals to deliver this clinic? We trained our AMPs over a period of 4 months, delivering clinics and signing them off when we felt they were competent. We then moved the consultation to a video consultation through the platform. We then started slowly introducing the remote monitoring aspect. And hopefully through this stepwise manner, introducing that digital change, we wanted to ultimately achieve some improvement for the system. So we started off really small with the 50-patient pilot. We had high patient satisfaction, a significant reduction in our DNAs, and a patient saved time and cost. What we were also able to show with pharmacy-led up titration in this small group, we were able to significantly improve their doses of prognostic medication. And we were able to do it in a small amount of time. The time to remotely monitor and send an up titrate and send the patient a digital instruction, they would get through 8 patients in 30 to 40 minutes. So the concept was shown to have some merit. As I mentioned, compared to our audit of 11% up titration of these prognostic drugs, in this 50 patients, we were achieving 85% and 70-odd% respectively. So a dramatic improvement. So then COVID happened, and that led this to become the default pathway for our patients. So this is just an idea of the number of patients we were seeing per month, and now it is dramatically increasing. This is the default pathway for our post-heart attack patients. We're seeing consistently over 100 patients per month via this remote pathway. We also introduced the concept of a next day discharge COVID project. During the height of COVID, we really wanted to see whether we can get patients out of the hospital, reduce the chance of patients getting COVID-19. And through this pathway, we'd already had some confidence that we could use remote technology to safely see these patients. So we had nearly 400 patients go through our early discharge pathway. So patients had a heart attack, discharged within 24 to 48 hours. And what we were able to show that the median stay of 29 when compared to 78 hours. We had 2 deaths that were after 30 days, but both due to subsequent COVID-19. But importantly, we had 0% cardiovascular death and 1.75% MACE. And we'd achieved still high patient satisfaction. And importantly, none of our patients got COVID-19 while they were in hospital. We've also started a trial with Astrazeneca. Now that our virtual enablement of up titration of secondary prevention drugs, a bit of a mouthful, but the first part of the journey was getting the ANP to deliver the virtual clinics using a remote monitoring platform, and they were doing the consultation in 8 weeks. This trial, every single heart attack patient is now given a blood pressure machine to take home. They are putting in their blood pressure and heart rates, and we have a pharmacist now who has a dedicated remote up titration and medicine optimization clinic as part of our 50-patient, pilot. And we have to report on this in the next few months. So hopefully I've given an idea of what is the art of the possible, using change management with the allied professionals that you've got, and utilizing digital technology at the heart of that, trying to improve and gain efficiencies. Thank you very much.